According to Mann and Malihi 2023, transcranial magnetic stimulation is a non-invasive brain stimulation technique utilized in many psychological disorders, including attention deficit hyperactivity disorder, obsessive compulsive disorder, depression, Tourette's disorder, chronic pain, and post-traumatic stress disorder. According to Mann and Malihi 2023, transcranial magnetic stimulation is a non-invasive brain stimulation technique utilized in many psychological disorders, including attention deficit hyperactivity disorder, obsessive compulsive disorder, depression, Tourette's disorder, chronic pain, and post-traumatic stress disorder. Transcranial magnetic stimulation, or TMS, works by attaching a magnetic coil to specific areas of the scalp that correspond with desired brain activity measures and pulsating an intense, brief magnetic field. An initial dosing session is generally required for all patients to determine their treatment intensity. TMS has been approved in over 25 countries within their varying specification and applications, with several countries approving the use of TMS for depression. Australia approved the use of TMS in 2007 and recently included TMS in the Medicare benefit schedule in 2021. While Australia has not formally recognised the use of TMS for attention deficient hyperactivity disorder, there are many clinics across the country providing these services. This is a result of limited knowledge and ongoing development into TMS for ADHD. According to a Parmigiani et al. 2023 review, motor evoked potentials in TMS have consistently demonstrated high validity and internal and external reliability in the excitability of the corticospinal tract, primarily due to consistency across its signal-to-noise ratio. TMS evoked potentials, the result of TMS pulses combined with EEG scalp recordings, exhibit high internal reliability as they can be repeated within a week. This is particularly relevant to the use of TMS as a form of treatment, as it allows patients to feel as though they are making developments and have a consistent routine outside of medication. However, as Parmigiani et al. 2023 noted, TMS evoked potentials are highly sensitive to small but relevant changes in stimulation site, angle, and intensity. The prevalence of TMS in treating ADHD is largely limited, as knowledge and understanding of how TMS affects ADHD is underdeveloped. However, findings are hopeful, as TMS treatment is a relatively old and reliable concept. Australian National University Professor of Psychiatry Paul Fitzgerald explained in 2023 that prior research on the temporary improvement of thinking abilities in disorders such as Alzheimer's is being applied to ADHD, but this research is still in its infancy. For clarification, ADHD was previously referred to as attention deficient disorder up until 1987, when it was modified to encompass hyperactivity symptoms. Now, ADHD is a complex and prevalent psychological conditioning affecting 1 in 20 Australians and almost 366 million people worldwide. According to the Diagnostic and Statistical Manual of Mental Disorders, Edition 5, Text Revised, ADHD is the persistent pattern of inattention and/or hyperactivity impulsivity that interferes with functioning or development. Both criteria must have 6 or more of the relevant symptoms that have persisted for at least 6 months to a degree that negatively impacts social, academic, and occupational activities and is inconsistent with developmental level. Several inattentive or hyperactive impulsive symptoms must have been present prior to age 12 and are present in 2 or more settings. Symptoms must also not be a manifestation of defiance or failure to understand what is expected of them, which is specifically relevant to young children and adolescents. Aksha Memmon's 2021 literature review into TMS use in case of adolescents' ADHD revealed that 10 to 30% of United States adolescents do not respond to standard pharmacotherapy. Study participants were found to have no major adverse consequences in line with other research. However, these findings are limited primarily to the US, with a singular international study included in the review and are generally over 10 years old. Gomez et al. 2014 and Weaver et al. 2012 were primary articles cited as they identified the outcomes of TMS use in ADHD in advancing the development of hyperactivity impulsivity in home environments and inattention in schooling environments. reiterating that as TMS servicing ADHD is relatively new, prevalence is limited. However, the current working theory is that TMS will increase synaptic plasticity, which is the brain's capacity to strengthen or weaken neurons, induce release of dopamine, and improve response inhibition. Overall, safety data from the use of single and paired pulse TMS and rTMS has been satisfactory in trials conducted thus far. Narrowing in on several studies' discussion on dopamine levels and synaptic plasticity, it is important to know why this is relevant to ADHD. Dopamine is a vital chemical messenger in high-level executive function, including controlling and driving motivation, focus, learning, and alertness, and has been labeled as the brain's reward system. Lowered or impaired dopamine production has been repeatedly linked to ADHD and is believed to be a major basis for it. Synaptic plasticity plays a fundamental role in strengthening or weakening neurons, which in turn affects their adaptation to experience and information. Additionally, TMS can inhibit the release of key neurotransmitters, including glutamate, which increases excitation, and gamma-aminobutyric acid, which increases inhibition. Findings on the efficacy of TMS treatment of ADHD are mixed. Fu et al. 2025 found that TMS significantly improved inattention and hyperactivity impulsivity within the 1-month follow-up, but interestingly, not immediately after intervention, with minor adverse events. However, they did note that rTMS efficacy cannot be concluded, for further studies with optimized designs are needed. They explained that the various stimulation parameters may not be suitable for the vast yet common range of ADHD subtypes, and therefore may be responsible for a portion of the discrepancy. Conversely, Chen et al. 2023 reported the therapeutic efficacy of rTMS for improving sustained attention and processing speed. Concurring with the majority of literature on TMS and ADHD, these findings were limited due to a lack of available data. Salani Hajjad et al. 2020 suggested partial improvement of ADHD symptoms and recommended implementing polarity and site relevance within stimulation for TMS and ADHD. There is a few physiological mechanisms of change suggested for TMS and ADHD, as it is in its infancy stages of research, although a primary suggestion is improving synaptic plasticity, like long-term attention and depression. By strengthening some cognitive behaviors and memories and weakening others, it is the goal to, for a lack of a better word, rewrite the chemistry of ADHD and limit symptoms. Articles cited have overwhelmingly called for more future research in general to provide a well-rounded understanding of the benefits and limitations of transcranial magnetic stimulation on ADHD. Some studies called for specific investigation into the association of brain regions, while others suggested surrogate parameters of clinical symptoms. There is an abundance of interest and hope for future developments in the relationships between ADHD and TMS, and therefore extensive research should be conducted to build a thorough understanding and application.